Okay, happy Memorial Day weekend. Thanks for joining me on this Sunday evening. I appreciate each and every week that you spend a little time with me and have trust in some of what I say. As always, I want to start off by thanking the Lupus Foundation of America, Georgia chapter with Terry Emond, and just of all the support, not just in times of pandemics, but really, I mean, what they're doing now is what they do each and every day. And also like to thank the Georgia Council for Lupus Education and Awareness, chaired by Chris Reed, and also on the board is Representative Kim Schofield. They do a lot of great things throughout the state, and hopefully we can learn more about that as the year goes on. And also my organization at Emory, but specifically we do a research project called GOAL that has shed amazing light on what we as a community have to deal with in terms of lupus. We hope to continue to shed light on that and spread it to the world in the future. Okay, well, news since last week, just talking generally about COVID. We went from 4.5 to 5.2 million cases globally, and up from 300,000 to 336,000 deaths. In the US, we're up to 1.6 million cases and 96,000 deaths. And continue to lead the world. Number 2 is now Russia. And quickly behind it, though, is Brazil, which is really a hot spot, so much so that the US has actually implemented a travel ban today, I think, along with China and Europe in terms of non-US citizens coming in from those countries. This is a website, statista.com. That's another source of really good statistics and numbers if you want to go to it. But here it lists the different countries in terms of total number of infections, active infections, recoveries, and deaths. And this is the New York Times map that I mentioned last week. It's a great website to go to here. Just Google New York Times and COVID map. You can see a whole bunch of different types of maps, but here it highlights in darker red colors the areas that have that are hotspots, meaning that they have a lot of new cases very quickly. And so the ones that are in darker red are the countries that have doubling of cases very quickly relative to the rest of the world. And you can see the hotspots, unfortunately, are in areas that are more developing and have less resources. So you can only imagine the toll that it may take or is going to take in those countries. And as I mentioned earlier, Brazil and other parts of South America, parts of Central America, and our neighbors in Mexico, countries in Africa are really starting to get hit now. When we talk about different countries, you may have heard about Sweden and how they're taking a very different approach. And what Sweden did was they basically didn't close and restrict as much, with the thinking that naturally people would get infected. You don't want to get too much infections, especially in the vulnerable, but to a certain degree, infections will occur just like the cold and the flu. And that would then lead to more and more people becoming immune to it. And generally over time, the country itself would have a certain amount of people that were previously infected and now immune. And so the term herd immunity has been in the news a lot. And so Sweden's approach to this was to be prudent in some regard, and that is to ban large gatherings over 50 and close high schools and colleges, museums, and major sporting events. They banned also visits to nursing homes. They encourage social distancing, but they trusted people to do so and not really enforced it per se. They emphasized hand washing, avoid unnecessary travel, But they kept their borders open, the restaurants and bars as well. Preschool and grade level schools remained in session. There were no limits on public transportations, outings, and all the hairdressers and so forth, including the ski slopes, which I guess are more important there than here, remained open. So can the Swedish strategy work in the US? And it's highly unlikely given some of the major differences. We have fewer people in single person households in the US, which would mean more chance of direct infection if one family member got infected. And then you know about the comorbidities, other medical conditions that put people at even higher risk for poor outcomes with COVID infections, including obesity and diabetes, which have much higher rates here in the US compared to the Swedish group. There's more of an individualistic approach in the US, whereas Sweden was able to implement this strategy with a fairly uniform approach, a uniform mindset. People bought into it as a group, as a country, more than anything that would happen here in the US. And related to this, there's less trust in government generally as a whole in the US, or more a heterogeneous perspective, so to speak. But in a way, if you think about the US reopening, we're basically taking a modified approach to the Swedish path, even though President Trump had bashed the way Sweden did it. In a way, we are following its path. And if the ultimate goal really, whether intended or not, is to develop some degree of herd immunity, we have an extremely long way to go in the US. The larger outside circle here represents the entire population, 325 million plus of the US. And in order to achieve herd immunity, you would need about 225 of the 325 million people in the US exposed, infected, and recovered with established immunity to COVID-19. And currently we have about less than 10 million. So it would come with a lot of hurt to get to that point. And to further underscore that, the approach in Sweden has not come without any hurt. And these are very weird graphs, I know, but on the right here are neighboring Scandinavian countries, Finland and Norway in the green and red colors. And this is time going from left to right, and going up and down are number of cases of confirmed COVID-19. And so over time, you can see that Sweden, as expected, would have more cases of COVID-19 relative to its neighboring Scandinavian countries that implemented more of a lockdown. But that came with an obvious price in terms of deaths, and it's a similar figure here in terms of the lines and what they represent. And you can see Sweden's death is at a high level, much higher level than compared to its neighboring countries. And so this is to underscore that when we talk about reopening, whether it's at a country level or individual states, the reopening has nothing directly to do with changing of the infectious nature of the virus, or whether the virus remains around or not. The virus is here, as I've said before, and it is highly infectious, just as infectious as it was 2-3 months ago. The virus doesn't read the news, it doesn't adhere to governmental edicts. So the virus is what it is. The potential for infections are still there. The whole reopening part of it and people going out more as a result of that is purely a result of a policy decision, a government decision that is striking the best balance as possible between a scientific and medical one, as well as a public financial, economic one as well. And it's balancing the two, because if you go up on one, you're going to go down on the other. If you go up on the other, you're going to go down on the other one. And the analogy that I've used in the past is like the speed limit. We know that speed limits of 55 will have a certain number of people who die as a result of car accidents from that particular speed limit. And if you raise that speed limit, you're going to have more deaths. And if you lower that speed limit, you're going to have less deaths. But then on the other hand, you need people to get from one place to the other with a certain amount of ease and efficiency. And so you just have to strike that balance. And this balance between economics and policy and medical and economic, it's a tough one. And it really comes down to balancing those things. And to some degree, it's an ethical question, because how much is one life worth or 1,000 lives worth? I'm not saying that I have the answer, but that's what reopening comes down to. And there's a lot of questions that continue to come, and these are reasonable questions. But it really shows how that the headlines and all of that really miss this point, that the reopening is not supposed to really mean anything to us as individuals. With you living, or someone that living with lupus, there's just as much risk of getting that virus. The lupus hasn't changed, your medications haven't changed, the virus hasn't changed. And so the reopening is just merely on a population level, looking at big maps, looking at economic numbers, overall deaths, how to balance the two. Obviously, the extremes can't work either way. You can't open up everything like nothing happened. On the other hand, you can't shut everything down indefinitely. People will die for other reasons, financial reasons. So the reopening is a policy level decision that you really need to try to ignore in terms of your everyday life, because none of that has changed. It means that when you're out in public, there are going to be more people around, but how you look at those risks, how you tackle those risks should be the same as it was weeks ago. So this ethical question is really a tough one. And again, I'm not here to judge anybody, but it's just a very tough balance, isn't it? We have people on one side, especially if you live with a chronic medical condition, that puts you at a higher risk for poor outcomes. And every time you go to the grocery store, you're seeing more and more people there, and out in the public where you may go through, and that puts you at a higher risk in general. But on the other hand, there are a lot of people who really want to exercise their individual rights and their financial freedoms. And that's one of the complex beauties of our country, isn't it? To come together with as one country to make a decision. But that's been tough, because there are a lot of different views, a lot of different states, a lot of different areas that are affected differently. And you can see the various areas, some more than others, that are afflicted or continue to be afflicted by COVID. The bigger the circles, the larger the numbers of cases. The Southeast in general, and you can see Atlanta, unfortunately, continues to shine amongst a lot of smaller dots. But clearly the East Coast, the Midwest, and the West Coast continue to be heavily afflicted. There are some promising areas. There are 19 states that have decreasing numbers. Unfortunately, there are 6 states that have increasing numbers. And then there are those in the middle that have stable rates, including Georgia. I mean, the glass half full part that's great. We're not increasing. The glass half empty part is we actually were in the decreasing column not too long ago. So is that a harbinger of things to come? We'll have to see. And also with regards to the regions involved, we talked about how certain other medical conditions like obesity, diabetes, high blood pressure, lung disease, heart disease, if you have those and you get COVID infections, that greatly increases your chance of poor outcomes and death. And so if you map the areas of the country that have really high rates of those other conditions, you can see it really lights up in the southeast. And then you talk about large areas where there's a lot of COVID infection, and you can kind of get a sense of where the highest risk of poor outcomes with COVID infection are, these really dark colors, which really light up in some of the rural areas of our state, big areas and swaths in Alabama, the Carolinas, West Virginia, Mississippi, Louisiana, Arkansas. So also new since last week, all 50 states are now partially or totally reopened. Massachusetts and Connecticut were the last holdouts, but they've rejoined to a certain degree. Georgia last week had 36,500 cases, about 1,500 deaths. And now we have 41,000 from 36,500 and 1,785 deaths from about 1,500. If you look at sheer numbers, given the population density of the Atlanta metropolitan area, it's not a surprise that the majority of the numbers will be in the Atlanta area. Oops, but if you take into account the population, the differences in population, and look at cases per 100,000, then you have a much greater impact continuing in some rural areas, especially in Southwest Georgia, around Albany. Despite, we talked about taking the figures and numbers from the Georgia Department of Public Health website with a grain of salt. We see here that cases over time generally seem to be coming down, but the projected, you can kind of see that it may be kind of hinting upwards. The deaths seem to be going down, and they're projecting it to go down. The top counties afflicted continue to be Atlanta, but you see a fair number of rural areas that are disproportionately afflicted. Over time, you see the new cases in Georgia. This is a different way of looking at it. And this is when the state reopened. And if you kind of look just at this point backwards, you kind of get a sense that it's going down, especially if you look at this big dip right here. But afterwards, you see a lot of dips up and down. And I guess any point, you can pick a point where you can either make it look bad or you can make it look good right at that point. Overall, though, all this up and down since the state reopened, you kind of get a sense that numbers are going down in general, although you're starting to see an uptick here. Whether that's a sustainable one or not, we'll have to see, but that's the fear. Similarly with deaths, you see deaths going up, kind of plateauing here. The state reopened based on projected numbers and trends to this point, and you see that the numbers are going significantly down, but right after the state reopened, it goes up, down. But again, you generally see a trend in the deaths going down. But just recently, this past week, we had the largest number of deaths in a day since right after the state reopened, and really only like third or fourth to all the previous highest numbers. So whether this is an outlier or a harbinger of things to come, we'll have to see. But the projected numbers of deaths per week and per day are projected to be on the rise compared to what we saw in the previous week. Again, on the left here, it just points out the increasing number of cases and deaths in Georgia over time. On the right here is what I've mentioned before, the density of cases, if you take into account the different population densities, you see that Southwest Georgia and other parts of rural Georgia are heavily hit. If you look at counties where the cases are doubling in a given week, you see this hotspot continues really at the south border of Georgia, here in Eccles County. Metro Atlanta, though, as I mentioned earlier or previous weeks, continues to be relatively doing okay compared to the rest of the state. You see here the total positive cases and those in the ICU with positive COVID are generally overall, you can see, coming down. Although the ICU cases have stabilized for the past several days, you wonder if there's an uptick coming in the total number of cases in the Atlanta metro area. So we always have to be on guard. This is regarding testing. The total number of tests are 407,731 in Georgia, which represents 3.7% of the total population. The positive tests out of all that were given are currently 9.6%, and our goal is to have it be less than 10%. And the reason for this goal is that the more tests you do, you're going to assume that you're going to get more negatives than positives. So you want the percent positives to be less than 10 as a reflection of doing a lot of tests, not necessarily reflecting the total cases of COVID going down, although we hope that they would be, that they would correlate with one another. But really the goal here is to really drive the number of cases, testing done. And the number of tests, and by the way, so I think, in terms of total number of percentage of positive tests, Georgia's doing better than it did before. So that's reflecting improvement in the number of testing. So if you look at it from the actual number of tests done per 1,000 population, we still are below goal, but improving from previous weeks. And we've made some dramatic strides recently. We did 105,000 plus tests last week, and the goal was to do about 10,000 tests per day. And just this past week, we exceeded that goal per day. So hopefully we'll continue this trend. But one thing that you may have seen is, a lot of tests states are doing well or better than before, including Georgia. So the WHO, the World Health Organization, is shooting for a certain benchmark based on percentage of population as to how many tests should be done. And you see here that over time, going from left to right, this green numbers represent the number of states in that given week or that point of time where the states met that WHO recommendation of having a certain amount of tests done. And then that steadily has gone up over time, and more states are doing better and better, which makes sense. And then you get this huge spike here. And what seems to have driven that, unfortunately, is that people are making mistakes, or if you're really pessimistic, people are cheating. If you set a goal, people are going to find a way to get to it, either from the proper way of doing it and maybe some slightly indirect ways of getting there. In Georgia, as well as Florida and other states, and even the CDC have, either by mistake or who knows, they've lumped together the actual tests done for infection, active infection, which is the PCR nasal swab. And that's what they're trying to increase the numbers of, testing people that are actively infected. And then there's the blood tests, the seropositive tests, looking to see if you developed antibodies, so you were exposed to the virus before at some point. It could be a week ago, it could be 2-3 months ago. Doesn't mean that you're actively infected. And so they were commingling those numbers, and that's why a lot of states really went from a certain level and they skyrocketed. Other things in the news this week, the state's not doing well, just like every other state in terms of the economic impact, but unfortunately the state has chosen to impact the budget of a department that has to do with our public health, the Department of Public Health. And that's not good to see. And just like in many other businesses, the healthcare industry is not immune, and Emory and Wellstar, and I'm sure other organizations you're going to hear, healthcare organizations, you're going to hear more news in the future about how the economic climate has negatively impacted them. Just wanted to inform those that live in the metro area, especially in the city of Atlanta. The mayor's office has put together a COVID-19 data website called atlstrong.org. And there you can find the plan for the city. And what I respect the mayor and the city of Atlanta for is that they're very transparent about how they're approaching their decisions, and it's data driven. And so you can see the plan as well as a dashboard that tracks the data that informs the plan. And it also includes a link to the Johns Hopkins website where you can drill down to the county level for information, as well as specific numbers for the city of Atlanta in the form of a PDF. So if you get a chance and you're interested, please go and check out that site. What also was in the news recently is that, well, even before this week, you may have heard that there was a concern that having COVID once does not protect you, or may not protect you from getting again. In other words, you may not build immunity to it. And that was based in large part from findings of people who were COVID test positive with symptoms being later found to be COVID test positive again, that nasal swab. And that was interpreted as meaning that these people were infected again. But the Korean groups have found that the second time people were tested positive, it doesn't necessarily mean that they're actively infectious or infected that second time. They showed that that second test was that PCR is the test method that they use, was detecting dead virus particles. So that actually gives a lot of hope in terms of immunity, and especially with regards to vaccines. And there was another bit of good news in that there was a company called Moderna in Boston that revealed very promising early results. Unfortunately, the big thing, in addition to that bit of news, which was the biggest news in and of itself, what would seem to garner most attention was really how it affected the stock market and the value of the stocks of that particular company. It's still very early, but we do have hopes of some of these vaccines that have promising results coming to fruition. And you can see the three going into phase 3 studies in the coming months. And phase 3 is really at the end of various stages. That is the step right before approval if you have positive and safe results up until that point. So the fact that we have 3 going into phase 3 is highly encouraging, cautiously optimistic about that. And each one of these phase 3 studies will recruit about 30,000 people. So you're talking nearly 100,000 people in the coming months will enroll in these trials to see whether one or more of these vaccines will make it to the world, and hopefully in many of us sometime soon. So the fact that these are starting in July, August, September, pretty much tells us that you're not going to see anything in your doctor's offices by December, but it'll be, again, if everything goes right, it'll be sooner than anything has come to market before. And I know some of you are asking when can I plan? Are my kids are going to be in school second semester, first semester? I don't know. But just know that people are trying really hard and it's going faster than we've ever seen before. Okay, moving to Plaquenil. It's back in the news and it's causing a lot of ruckus. And so I'm going to go further into detail of that. A lot of the ruckus is behind some of these complications. So I wanted to take you back to what I presented a few weeks ago. First is a Brazilian study of hospitalized COVID positive patients that used chloroquine, a cousin of hydroxychloroquine or Plaquenil, at 2 different doses, and everybody got azithromycin, this antibiotic. And this study was stopped early before they even can have any sense of whether chloroquine worked against COVID or not, because they started to see a signal where there were more deaths in the chloroquine group than chloroquine plus azithromycin group than those who were not. And it was so much more in the chloroquine groups and azithromycin group, that's 16 out of 41 compared to 6 out of 40 in the other group. And that was way more than would be by chance. That from an ethical perspective, it was just too dangerous and they stopped the study. It was one study, it's a smaller study than we would have liked, but yet it's an important signal early on. And then the VA did a Veterans Administration did a study looking backwards or retrospectively at 368 COVID positive hospitalized patients in the VA hospital system throughout the country. And this is, these patients were not determined to be on Plaquenil or not based on a clinical trial, in a prospective clinical trial. A prospective clinical trial means, okay, I'm entering a clinical trial, we're gonna decide to do this or that based on whatever parameters, and then we're gonna follow to see what happens. Now, these were followed after the fact. They looked back in time and doctors and patients made their decision to put someone on Plaquenil plus azithromycin, or neither one of those, based on whatever they felt was in the best interest of that particular patient and the knowledge that they had at that time. So it's a very different environment. But anyway, despite all of those flaws, if you will, and nuances, this showed that there was a higher risk of death in the groups that had Plaquenil in them for whatever reason. And then when you combine those 2 studies at that time, a few weeks ago, and other data, the FDA, rightly so, issued a warning about hydroxychloroquine for COVID-19. And they said that if you're going to use it in very sick people with COVID-19 in the hospital, then it needs to be in a very well-controlled, monitored situation. Either you're part of a clinical trial where they follow it extremely carefully, or you're in the hospital, or both, preferably both, or presumably both, because the really sick ones in the clinical trials at that time were mostly in the hospital anyway. So basically, these are really sick, by definition, hospitalized, COVID positive patients taking Plaquenil for treatment against that infection at that time. Excuse me. So what really caused a brouhaha recently was the admission by President Trump, after having a couple of people in the White House be tested positive for COVID, that he was taking hydroxychloroquine as a preventative drug. And that was on May 18th. And then on top of that, this past week, The Lancet, which is a prestigious medical journal, published a study where the authors reviewed data from a multinational registry, and they used computers to delve into multiple countries' data banks of very complex data. And they found, tons and tons of patients. It's like from 671 hospitals across 6 different continents, a very complex data crunch, if you will. They looked for people who were COVID positive and in the hospital, and they found basically that those that were on hydroxychloroquine or chloroquine with or without a macrolide here is azithromycin. It's the class of antibiotics that azithromycin is in, that those were at increased risk of arrhythmias and death. And so that then triggered a ton of these headlines, which lumped very different concepts, and it drove me crazy. And I knew that the effects on many of you and others who were taking Plaquenil for lupus and have been doing so for a while would see these things, rightly so, and get scared, because when you're talking about a drug that you're on and being linked to increased death, heart arrhythmias, then it gets really scary. And so nothing has changed really since that FDA warning a few weeks ago. This is old news, really. And they're mixing up what President Trump is doing, which was more of a preventative measure. He was not actively infected with COVID. He was taking it or trying to take it to see if it might help prevent the COVID infection, which, by the way, again, I want you to know that there is absolutely no proof of that. But, rightly so, I think his personal physicians were saying that, generally speaking, unless you have an active COVID infection, it's a pretty darn safe drug. And that's why many of you take it. So nothing has changed since this FDA warning, but the headlines make you think that all of a sudden hydroxychloroquine is a dangerous drug in general. And that for someone who's otherwise healthy, as far as we know, and someone like President Trump, it's a bad thing to take. That is not true. So the warning really, as it relates to being hospitalized with COVID and taking Plaquenil, is around and remains. And what we've learned since that time of that original FDA warning, which helps explain what we're seeing in the hospital with this COVID infection and Plaquenil and increased risk of arrhythmias and deaths, is that COVID-19, among many other things that we're finding out recently that it does, is that it too can attack the heart in addition to the lungs. It causes a lot of inflammation of the heart. And that in and of itself, sorry, hit the wrong button. So COVID in and of itself can irritate and inflame the heart and put somebody at increased risk of the arrhythmias by itself. The virus, the infection alone in a really sick patient, in many of those, we see a fair number of people that have inflammation, irritation of the heart that puts themselves at a higher risk for arrhythmias, regardless of whether they're taking Plaquenil or azithromycin or anything else. So then it makes sense that if you add other medications that are known theoretically to make it easier to have those arrhythmias, like Plaquenil and chloroquine, and we've known about this, and azithromycin too, by the way, which Makes me wonder why those original researchers in France decided to add azithromycin to Plaquenil. I don't know why they chose that antibiotic. And it was, in retrospect, it was a poor choice in some sense because azithromycin is known to increase arrhythmias by increasing what we call the QT interval. It's EKG phenomenon that we see that can lead to arrhythmias. So we've known about the risk of arrhythmias, this QT prolongation with Plaquenil and chloroquine for many years. But the reason many of you probably have not heard about it until recently is that we know that Plaquenil or hydroxychloroquine is absolutely safe in rheumatoid arthritis and people with lupus, even though these are conditions that have a lot of heart and vascular issues. But the heart issue tends not to be the type that you see in COVID with such acute inflammation of that degree. I mean, there can be a variation of heart involvement in lupus that we do see a lot of very brisk inflammation, but in general, it's not something that you see. We prescribe Plaquenil very frequently, meaning the medical community, especially the rheumatologists. And as you know, we prescribe it for a very long period of time because the benefits for Plaquenil is really in long periods of time. Because we have significant and consistent, a lot more data than you see in anything in COVID that point to the safety of Plaquenil and its beneficial effects in people with rheumatoid arthritis and lupus. And there have been extremely few heart events as a result that's been shown to be directly resulted to those medications, let alone any deaths. So relatively few that we don't even bring it up. And I take this quote out of a cardiology journal. It's a very well-known, prestigious journal called Circulation, and this is published in 2009, way before this pandemic. And their quote is, "Several hundred million courses of chloroquine and hydroxychloroquine have been used worldwide, making it one of the most widely used drugs in history without reports of arrhythmic death under World Health Organization surveillance. And since 2009, there have been millions and millions of more doses since then, and it's been extremely safe." So the take-home points are, active and severe COVID infections can irritate the heart and increase the chance of heart arrhythmias by itself. We almost never see any severe heart issues due to Plaquenil and chloroquine in lupus or RA. So when you combine a bad COVID infection with certain drugs, the risk of heart arrhythmias and deaths can increase. So for those of you living or know somebody living with lupus and taking Plaquenil, hydroxychloroquine, or chloroquine, as prescribed, it continues to be, and it remains one of the safest medications we use for these conditions. So that begs the question, if you develop an active COVID infection while on one of these medications, you need to speak to your doctor about it, about whether to continue or not. But apart from that, you should not have any necessary fears about that. So that brings up some questions that have come up this week. Is there a danger of being on Plaquenil if you contract COVID-19, since I think there's been reported the higher mortality rate that we discussed? And would a lupus patient who contracts COVID-19 be taken off Plaquenil while trying to recover from COVID-19? And if so, what could that do to their fight against lupus? So the chances of getting a COVID infection are still pretty low. And you already know that you have lupus. And so if you've been prescribed Plaquenil, advised to take it, have been taking it, feel as though you've been benefiting from it, the benefits heavily outweigh the risks. But God forbid, if you were to develop a COVID infection while having had taken Plaquenil for many years as a part of your lupus, then we don't really know whether you're negatively impacted or not, having had taken the Plaquenil for so many years as a part of regular care for lupus. And that's part of the reason why we need more information. But I can tell you that there has not been any signal of that so far that we can tell. And so there's no reason to think that you're going to be any worse off. And if you were to develop some lupus-related issues while being infected with COVID, and you were taken off your Plaquenil, there are many other ways to treat a lupus flare in the time to bridge you through the time of the COVID infection, if you were to have a flare during that time as well. And eventually you could get back on the Plaquenil if you chose to. So there are a lot of options here. So we can talk about the if games to the 10th degree, but it's really going to drive you mad. And you're talking about events that become dramatically less and less probable. So it's not really worth going down that road. But just focus on the things that have the most probable chance of positive impact now. And that is, if you're on Plaquenil and you've been benefiting from it, there's no reason to stop. Here's a couple other questions. We already have Plaquenil in our system, so do we start at a disadvantage? I would like to know what my 25 years of taking Plaquenil has done to my entire body. This particular person hasn't taken it in a while. I want you to put into perspective why we rheumatologists and others seem to have a love affair with Plaquenil. We give it a lot. It may not seem to be doing all that much in the short term. It's certainly not, for most people anyway, a dramatic drug like 100 milligrams of prednisone. And for those of you who've been on high doses of prednisone, you know what I'm talking about. You generally can feel something different within a couple of days, whether it's a positive or negative thing. With Plaquenil, for the most part, it's not something that is used for acute flares. It can be used for some mild joint and skin inflammation, but we tend to use either topical steroids, low-dose prednisone, other things. But the reason we start Plaquenil or we keep people on Plaquenil is really the long-term effects. And it's not something that you notice right away. When you're talking about things that occur over years, that have an effect gradually over years, it's not something that you look back and say, oh yeah, that made a big difference. You just don't notice it. But here, this is one of the big studies in our field of rheumatology. It was published in 1991 in the New England Journal of Medicine. And one of the major reasons that we advocated for taking Plaquenil ongoing, whether things are actively flaring in lupus or not, and the reason why I call it to people like a lupus vitamin, just keep taking it every day as long as you don't have any problems with it, is that in this study where they randomized people who have been doing fine with lupus on chronic Plaquenil, half to continuing Plaquenil and half to taking a placebo or a dummy pill. It was blinded. They didn't know which group they were in, and this was consented. Everybody knew that they were going into a study like this. At the end of the day, there was less severe flares in the group that remained on Plaquenil. And so does Plaquenil prevent lupus from flaring? No. Is it a cure? No. But in general, there are the people who remain on Plaquenil tend to have fewer flares. Are there people on Plaquenil that have flares? Yes. But statistically, generally speaking, it seems to have a calming effect. It reduces the number of flares. And so perhaps maybe if you did get a flare on Plaquenil, it would have been worse. So it does have a general effect. And then this is one example of other studies that people with lupus who remain on Plaquenil have fewer deaths. They have improved survival. And even when we control for confounding by indication, and that means, well, maybe people that are taking Plaquenil just tend to have milder disease, and that's why Plaquenil seems to be associated with improved survival, because that's a milder drug. And if you're having severe kidney issues and brain and heart issues, Plaquenil is not the go-to drug. There's a statistical way of controlling for that and not having as an issue. And this study and others have showed that Plaquenil seems to, over long periods of time, be associated with improved survival. And then there are a variety of other studies in terms of cholesterol levels or lipids. And people with lupus that were also taking prednisone, those that were taking Plaquenil had a reduction in the cholesterol levels. In rheumatoid arthritis, when you take Plaquenil, it decreased total cholesterol and the bad cholesterol, the LDL and triglycerides, along with increasing the good cholesterol, the HDL, compared to those that were not on Plaquenil. Interestingly, in rheumatoid arthritis, those taking Plaquenil had fewer cases of developing diabetes. And this intrigued some pharmaceutical companies enough to kind of explore whether Plaquenil may be a drug or used in combination with other drugs improve diabetes. That obviously didn't go that much further because there's nothing out there that's approved for Plaquenil in diabetes. So I don't want you to take it if you have diabetes for this purpose. But all that's to underscore that, you know, this is just one of the very positive things that's been seen in people with RA that were taking Plaquenil, and presumably it may have an effect on people with lupus. And those with lupus that have clotting tendencies, that have this marker, these antiphospholipid antibodies, had lower rates of blood clots than those that were not taking Plaquenil. So Plaquenil prevented blood clots in people at higher risk with antiphospholipid antibodies, or had lower rates of blood clots. So when you add up all those things together, and yes, there's a potential eye issue, and I'm not saying it's safe for everybody. Those things are very rare. You should get eye exams regularly. You should talk to your doctor. Not everybody needs to be on Plaquenil but for the most part, I mean, if you're one of my patients or you've seen me, you know that I generally recommend it for people to continue to take if they're able to tolerate it, don't have bad side effects, and they can afford it. All right, it's a question here. Should we still be following the social distancing rules? Lots of conflicting information. You know, now that some of the numbers are going down, am I still at risk? So another way to frame the question is, well, what's the evidence? What did social distancing do? And if you look at the experience in Seattle and the rest of Washington State, there was definitely a decrease in positive infections when they implemented social distancing. And even if you remove the influence of increased testing, because remember I said the more you test, the lower the percentage of positive tests will be, because you're going to get more people who are negative as well as some people that are positive. So even if you remove that, and they can factor that in, the social distancing independently drove a reduction in people getting infected. And then when you talk about social distancing and how that it's still, you know, part of the reason why the whole claim to success of reopening the state can't be completely in the arms of the politicians meaning the politicians cannot claim complete victory over the fact that we haven't had a huge uptick in cases yet, even though the state reopened. And a big part of that is that a lot of people continue to exercise social distancing despite the fact that the state has reopened. And if you just look at one measure of this, you look at on Open Table, the number of reservations made for restaurants, it's ticked back up a little bit, but not very much compared to what it was before by any means. And up until recently, I'm not sure how many churches really took heed to a lot of calls to open up, but a lot of churches do remain closed. And these institutions, these businesses, organizations, along with many other groups and individuals, it's exercising and practicing that social distancing that has really kept the infectious rates lower. Remember, it's not going to remove the infection. So the risk as an individual with lupus of being out there in the public is going to remain. And it's no different than a few weeks ago. So you need to practice your social distancing. You need to protect yourself. You need to wash your hands, minimize exposure to the best that you can. But generally speaking, the overall numbers have not been dramatically elevated yet because of what we are doing, and not necessarily because of what any organization or state or entity is specifically doing. It's actually in spite of all of that things are remaining low. And in spite of calls for houses of worship to open up and things to just be like they were before. And another way to kind of underscore how effective social distancing is that, remember, the general flu, the one that we've been used to over the years, that was just dramatically cut the rates in terms of when the social distancing measures were implemented. Okay, we're finishing up. This question, again, we've really, this is a longer session. So this question was actually addressed in the session last week. So whoever asked this, please go back and to the link of the previously recorded ones, and you can get a more detailed question or answer or discussion to this question. Just know that it really depends on the protections and the protocols. And I talk about an article there that talks about the parameters that I think all of us are aware of, but it's good to be reminded of that as you evaluate these new places that are opening up, including the pools during the summer and all of that. So whether it's not a matter of me recommending or not recommending people go or don't go, it's a matter of me and all the healthcare providers, your healthcare team, equipping you with the best information so that you better understand the risk-benefit ratio of things, so that you can put all of those things, those decisions in the context of your priorities. How badly do you need to go to the pool? For some people, they don't ever go to the pool. So for them, just even a slight increased risk, it's just not worth it. Why would they go to something that they don't want to go? But if you're really dying to go to the pool, or your kids have to go to the pool, you have no other alternative. I mean, it's something that mentally is going to mean so much to you. Then your level is that much higher, and in terms of the risk that you're willing to take on, but you have to know how to minimize the risks that are there to the best of your ability. And that goes into all the different things we discussed last week. So I'm going to wrap it up here. It's been an hour. Just to remind you of Terry, thank you. Thank you, the rest of the chapter, Lupus Foundation of America, Georgia chapter. Go to the website that continues to be updated. There's a COVID resource page. Please continue to send us your questions to info@lfaga.org by noon of the Sundays, and I'll keep coming here. I think we may discuss some changing of timing or the format, but it's really up to Terry and you all and your comments and your needs and the willingness of other people maybe to come in and talk. But at a minimum, I'm here as long as you guys need me. I only see people with lupus. I research lupus every day. I live and breathe lupus. I don't know any other rheumatologist that does that, practicing rheumatologist in this state or near this region. And that doesn't change with or without the pandemic. And so I'm here. Finishing up with this cartoon, but thank you all so much. It was really good being with you on this holiday weekend. Thank you for sharing just a bit of your time, and have a safe, wonderful, enjoyable Memorial Day. Remember all of the brave men and women who fought to give us the freedoms and the country that we have today. Have a good week.